I'm waiting on Peter. Queuing up Peter. Single. Everybody hear me okay? Ooh, he said I had to talk loud in it. Apparently I talk louder than I should. So, everybody hear me all right? Thumbs up. Hey, what a beautiful day. We're back together. Spring Forum today. Our last was in 2019. A couple years went by. There was something that happened during that time. We're not even going to mention it today. We have no masks on. Looking at each other, see the smiles. So, welcome everyone. Again, my name is Paul Moling. I'm a family medicine physician. I serve in many different leadership roles here at Mayo Clinic Health System in La Crosse. I'm here as head of our advancement committee who helps put all this together. Our group is to focus on the community and the well-being and health of this community and how we interact and engage. First and foremost, the biggest thing I want to say today, and these people are fantastic, is our auxiliaries. 70th year anniversary for them. That's incredible. Incredible. If you've ever had the ability to interact with them, you know who they are, and they're selfless. At this time, I'd ask you to stand, those auxiliaries in the gallery here. So, this is a huge hand. Thank you for everything you've done. Over all the years, the geranium sales, the donations to our community, and our nursing scholarships. I'm proud to call them friends, colleagues. They know to call me when they need help or assistance. I'm at their beck and call, and they know it, and they're over there smiling at me right now. So I'll do whatever I can for them. At this point in time, I'm going to bring up Dr. Paul Mueller. He's a regional vice president and physician leader here in La Crosse. Welcome, Paul.
Well, thank you, Dr. Moling, Paul. I think everybody knows that Paul's a tremendous leader and has been someone at my right hand for the last 5 years to lead what I think we would regard as transformational change. So thank you for your tireless efforts and being such a force in our community. I too want to thank our auxiliary, 70 years and going strong. That's tremendous. And I hope that everyone buys geraniums at their upcoming sale. I was actually approached because my name is not on the list yet, so count me in. We need to do all that we can to support nursing students and students in all health professions and keep them here when they graduate. With this being our first forum back in person, I want to thank all of those who joined us for the virtual community forums that we started not long after, I'm going to say it, the pandemic started. That, I believe, 3 years ago. And of course, you probably are all aware that Mayo went maskless yesterday. And the smiles you see on our staff are tremendous. And just reflecting a little bit on that, if you recall, we really didn't know much about the virus 3 years ago. We didn't have treatment, we didn't have a vaccine, and things have changed dramatically thanks to the hard work and the role our organization played in discovery, coming up with effective treatment plans, rolling out the vaccine, and keeping our community safe. We actually had 10 forums using Zoom as the webinar format, and more than 6,500 people registered for the live presentations, and tens of thousands more watched them on recordings, including through Facebook. So I'm grateful for the expert presenters we featured in these forums, and to all who tuned in from near and far. It feels great to be back in person, and for me it's especially gratifying to represent our organization and our tremendous staff. It's a team that continues to earn awards and distinctions for safety, quality, innovation, to the point where it's sometimes difficult to keep track of all of them. But what's far more important to us than the awards is keeping our focus on providing Mayo Clinic care in the community. This is in alignment with our primary value, the needs of the patient come first, and our Mayo Franciscan values to which we adhere closely and love. There's a reason Forbes magazine named Mayo Clinic Health System the #1 best employer to work in Wisconsin. It's our people and their exceptional commitment to caring for patients and each other. I'd like to take a moment to update you on our new hospital project. If you've been anywhere near West and Market Streets, you've seen a beautiful new state-of-the-art facility taking shape before your eyes. 1 year ago this month, we broke ground on this nearly $200 million hospital, and I think you'll agree we've come a long way. And we've done it by assembling talented construction crew involving many local and area contractors. I get that question with some frequency. They've worked through long days and occasionally some tough weather and through supply chain dynamics with which we're all familiar. This has had major impacts on projects elsewhere, but we are on track, on time, and on budget. It's going to be a beautiful Mayo Clinic building, but the real gift to the region is the quality of care and the Mayo care that will be delivered in it for generations to come. We look forward to sharing much more about our new hospital and our plans for the future in the months ahead. Today we're here, however, to talk about an important component of good health, one that can be challenging. It involves healthy weight and some of the challenges folks deal with if they have overweight or obesity. Involves how we manage weight. And we have 3 expert presenters who will offer several perspectives. Our first speaker is someone you may be familiar with, especially if you read the La Crosse Tribune, as she's appeared in the newspaper for the past 6 years with advice on healthy eating and some great recipes, including a couple of them that are included in your folder today. She's a registered dietitian nutritionist for Mayo Clinic Health System, and she will discuss the role of nutrition in the context of weight management. Please welcome Jamie Prunchinsky.
Hello, everyone. Like Dr. Mueller said, my name is Jamie. I'm a registered dietitian, and I'm going to be talking about the role of nutrition in weight management. So the connection between food and health has been well documented for decades. Evidence suggests that following a healthy lifestyle, which includes eating a healthy diet, can improve our health and reduce our risk of both acute and chronic health conditions, including type 2 diabetes, heart disease, and obesity. Although our specific needs for calories and nutrients really does vary throughout our lifespan, the core components of a healthy diet remain quite consistent. Current dietary recommendations focus on overall patterns of eating rather than individual specific nutrients. These patterns of eating that have been shown to improve health include lots of fruits, vegetables, and whole grains, moderate amounts of low-fat dairy products, and a variety of different protein sources, including those from plants like beans, seeds, nuts, legumes, and soy foods. It also includes healthy fats. So I think about healthy fats, kind of rule of thumb is they're liquids at room temperature, and they usually come from plant sources. So think olive oil, canola oil, but then also the fats from things like seeds, nuts, and avocados. These dietary patterns also limit red and processed meats, added salt and sugar, as well as unhealthy fats. So a rule of thumb with unhealthy fats is they usually are solids at room temperature and come from animal sources. So think butter and lard. The current nutrition guidelines for Americans encourages choosing nutrient-dense foods and staying within our calorie goals. So we'll talk a little bit more about the principle of nutrient density. Each of these plates contain roughly the same amount of calories. Does anyone want to shout out a guess as to how many calories each of these plates contain? 100, 180? 200, winner, ding, ding, ding. Yes, each of these plates contain roughly 200 calories. So you can see the difference in volume between the apple, the carrots, and the broccoli compared to the volumes of the butter, peanut butter, and cheese. That's because fruits and vegetables are considered to be nutrient dense. Because of their high fiber and water content, they supply few calories in a large volume of food, and then lots of nutrients like vitamins, minerals, and antioxidants, compared to the foods higher in fat, like the butter, cheese, and peanut butter, which we consider to be calorie dense, meaning lots of calories in a small volume and relatively fewer amounts of nutrients. Fat is is the most calorie-dense macronutrient at 9 calories per gram compared to 4 for protein and carbohydrates. So an example of an eating pattern that emphasizes nutrient-dense foods is the Mayo Clinic Healthy Eating Pyramid. So the idea with the pyramid is we eat most of our food from the groups at the bottom and then fewer from the food groups nearest the top. So fruits and vegetables can really help bulk up our meals, provide satiety or fullness with relatively few calories. So in order to achieve this diet pattern, we have to plan our meals around fruits and vegetables, or I encourage patients to choose fruits and vegetables with all meals, and then a variety of other food groups to help create a nice balance of healthy carbohydrates, protein, and fat. All right, you're going to hear from Dr. Dilger and Dr. Greenwell later on about all of the factors that influence our weight. It is complex and multifactorial and so much more complicated than just calories in, calories out. However, we do know that our diet and lifestyle habits do impact our weight. And in order to lose weight, we need to create a calorie deficit. So we can create this calorie deficit in a couple ways. We can decrease the amount of energy we take in from foods and beverages. Practicing portion control can help, eating a little bit less, or focusing on increasing our intake of those nutrient-dense foods like fruits and vegetables and eating smaller amounts of those calorie-dense foods. We can also increase our energy expenditure through physical activity, purposeful exercise, or increasing our activities day to day. So the stuff we do day to day, parking a little further away, taking the stairs at work, we call this NEAT, non-exercise activity thermogenesis. So burning calories, just doing stuff day to day. And another important part of this process is self-monitoring. So self-monitoring may be calorie tracking, it might be food logging, it might be fitness tracking. This is a strong predictor of success. We know that patients who journal, track in some form, typically do better with their weight loss efforts than those who don't. I think one of the ways that this can be helpful is that it builds mindfulness or awareness around our behaviors. And once we have that awareness into our behaviors, it allows us to make changes to them. I also think tracking can help us be accountable to our nutrition or physical activity goals. So maybe we know what healthy eating looks like, or we know what we should be doing, but we struggle to follow through with it. This is where meeting with a registered dietitian may be helpful. So a registered dietitian can partner with you to develop a personalized nutrition plan that takes into account your medical conditions, your finances, your time, your cooking abilities, your food preferences. We'll also work with you to identify barriers or things that prevent you from being successful and help you brainstorm solutions for overcoming those barriers. With a dietitian, we'll also help you set goals, realistic, achievable goals, and then we can always follow up with patients, and that follow-up can help with accountability and long-term success. So this is just an overview of the different pathways of weight management we have to offer here at Mayo Clinic, and you're going to hear about the additional pathways from our next speakers. But you'll notice one part, the part highlighted at the bottom is the part I just talked about. That is the base of all interventions we have to offer. There's no getting around this. All interventions we have to offer rely on our ability to make and sustain those behavior changes. However, we know with just diet and lifestyle alone, patients typically lose just modest amounts of weight, maybe about 5 or 10%. And with additional interventions, the amount of weight loss typically increases. So if you're considering additional interventions, like you'll hear about from our next speakers, meeting with a registered dietitian may be helpful, as this can help with the diet and lifestyle changes to help each of those interventions be successful. So I'll take questions at the end. This is my last slide, but I'm going to next shift our focus to our next intervention, which is medical management for weight management. And I'm going to introduce our next speaker, who is a family medicine provider in our Onalaska clinic. Please welcome Dr. Dilger.
Well, thank you for having me. This is one of the topics I really enjoy speaking about with my patients. Obesity is something that's a very common problem, and we've been getting more and more treatments that are available to us to help manage it. So it's really exciting to be able to come up here and talk about really what's available and kind of what's state of the art, what can we do for patients to help promote weight and really promote overall improved health. Because at the end of the day, that's what we're all trying to do. We're trying to improve long-term health. We're trying to improve someone's quality of life so that they live longer, healthier lives. So what I want to do is kind of go through a couple different things. So the goals I want you to be able to take away from this is really kind of understand, number one, what is obesity? And not just that, but beyond what obesity is, why do we care so much? What diseases are associated with it? Why are we treating it? Additionally, I think it's important to talk about some of the underlying issues that cause obesity, because if we understand those, we can start to individualize treatments and target treatments for people to more effectively treat obesity and improve their health. And then the other thing I want to touch on before the end of my talk is really what's the role of exercise in terms of weight management. You heard about diet. Diet and exercise, I think, are really the cornerstones, the foundational aspects of any weight management program designed to improve someone's health. Medications are helpful, but without those kind of that underpinning, it's not really the way we want to go about treating it, just throwing pills or throwing medications at a problem. So that's what I want to talk about today. So just to start, really, what is obesity? And at its core, obesity is a disease where someone accumulates excess body fat. We have multiple ways of measuring that. The most common one that most people are familiar with is what we call body mass index, or BMI. And the image up on the right side of the screen, or left side of the screen, excuse me, really goes through and shows kind of that we try and separate obesity into different, what we call classes. So class 1 is more mild obesity, moderate obesity is class 2, and severe obesity is class 3 with a BMI of 40 or higher. Body mass index is really comparing someone's weight to their height. There are other ways to measure it, but that's the one that's really gained the most acceptance in clinical practice, so that's what we use. The reason that we look at those numbers, the reason we put it into classes is because people at higher classes are going to be more likely to develop associated illnesses, and that's what's shown on the other side of the screen. So someone that has obesity is much more likely to develop things like high cholesterol, high blood pressure, type 2 diabetes, liver disease. Even things like anxiety and depression are associated with obesity. Dementia is associated with obesity. And in addition, we know certain cancers are associated with obesity too. So our hope is that by treating the obesity, we lessen someone's risk for developing these other conditions. So it's not just about reducing body weight. Like I mentioned before, it's about improving health overall. So this is a busy slide. There's a lot of stuff up there. You don't need to pay attention to that. The point of it is that obesity is complicated. There's a whole web of interacting factors that contribute to someone developing obesity. On top of that, we see that it's becoming more and more common as time goes on. So we saw a lot less obesity in the 1960s than we see today, and there are a wide number of factors that have led to that predisposition to develop obesity. So whenever you look at kind of that complicated web, there are many different things that influence someone's predisposition to develop obesity. Age, genetics, what's your physical activity level, what kind of foods do you eat, stress plays a role, sleep plays a role. All of those things interact in relatively unpredictable ways to increase body weight. So it's not just a disease of willpower. It's not just eating less. That's not how you treat obesity, because if you just focus on telling someone to eat less calories, more often than not, you're going to fail. And a lot of patients that I see are discouraged because that's been the approach in the past. The last decade or so, there's been kind of a sea change in terms of how we manage obesity, and it's focused around this idea that obesity is a disease. It's like high blood pressure. It requires management over someone's lifetime. You can't just treat it for a few years and then call it good. It's an ongoing problem that needs to be addressed to improve overall health. So one way to think about how the body regulates weight is imagine an air conditioning system, which now that we finally got some warm weather, I think most of us are probably turning on at some point here in the next few days if it's actually going to hit 80 degrees. So you set a set point on your thermostat, and the job of your air conditioning system is to maintain that set point. So now let's say it's 100 degrees outside. You've got a lot of sunlight beating down, the ambient air temperature's trying to warm up the house. Let's say you have some friends over, so you've got more bodies in the house. Let's say you make a meal while you're there. You've turned on the stove, now there's extra heat. All those factors are working against that set point to try and raise it. Eventually, you might notice that your air conditioner is running around the clock, and you don't want your compressor to fail, so you go and you turn it up from 72 to 76. That's the new set point. Your body regulates its weight in much the same way. So it's got a set point. With excess, with kind of these outside factors weighing in on that set point, it can be raised. And then it makes it very difficult to go below that set point because your body's fighting against you to maintain it. So imagine someone that graduates from college, healthy young adult, weighs 160 pounds. They get their first job. They're not as physically active because now they've got a desk job. They're a little bit more stressed. They're not getting as much sleep. They're not doing all the exercise they used to do. The set point goes up. Now they weigh 180 pounds. A few more years goes by. They have kids. They've got less time to dedicate to other activities that involve physical activity. They're now in a management position. They're more stressed out. They're getting less sleep. Their set point goes up to 200 pounds. That's what happens to people. That's why you can't just target calories. It's about addressing that collection of factors to help reduce weight. So, diet's obviously very important. It's a critical component of a weight management program. I'm going to talk about exercise at the end. The next thing I'm going to talk about is how do we address people with that excess body fat? How do we address that problem to help lower that weight and improve health? So this gets at the idea of medical treatment of obesity. How do we manage it with medications? These medications shouldn't just be used in isolation. That's one thing I want you to take away. They need to be part of a comprehensive management plan to address someone's weight. There are many different options that are on the market for weight. There are medications that have been on the market for years, like phentermine. There are newer options like Wegovy, or semaglutide, if you've heard of any of those medications. They range in effectiveness. Some medications will promote more weight loss than others. A medication like phentermine, we will typically see about 5 to 8% additional body weight loss whenever someone starts that medication. A medication like Wegovy, we see more like 12 to 15% of body weight loss, and a third of people will lose more than 20% of their total body weight. So if you look at that person that weighed 200 pounds and say, all right, we're going to treat this obesity, and we start them on a medication, we'll see anywhere from 10 to 30 or more pounds additional weight loss as a result of starting those medications. And when we reduce that weight, we improve health over the long haul for that person. It's important to continue those medications long term. So we can't just treat it for a year, get them to the goal weight, and then stop it. These are medications that need to be continued for years. Like I previously mentioned with high blood pressure. When we treat that, we don't just give someone a pill, get them to the right number, and say, you're good, and then stop the medication. We continue the medication over that person's lifespan to reduce their risk of developing other diseases related to high blood pressure. Same idea here. These are long-term medications. They're safe. They're continually monitored for adverse events. Some weight loss medications, like I'm sure most people remember Fen-Phen in the 1990s, those get pulled off the market because we begin to see that there are adverse events. So even though that's been a concern with weight loss medications in the past, there's ongoing monitoring for all these to ensure that they're safe for the people that are taking them. So like I mentioned, in general, about 5 to 15% weight loss is what most people can expect whenever they start a medication to help with weight loss. It's a decision that needs to be individualized. So that entire complex web that I showed earlier, that's what we're trying to pick out those factors that contribute most to someone's obesity and treat those factors specifically. For example, let's say someone has issues with food cravings. They get home or they've eaten their dinner and they just crave Oreos. They are getting ready for bed and they have food cravings at bedtime. Some of these medications are actually known to help with food cravings. Contrave is the name of one of them. That medication for that person might end up being a better option than some of the others. So it's a highly individual decision that takes into account underlying medical factors, the goals that we're trying to achieve, and really any other medications that that person might be on. So we want to make sure it's the right choice because, like I mentioned, these are long-term medications. We don't want to put you on something and then all of a sudden switch to something else because we weren't paying attention whenever we did it. It's important to get it right. In general, they work in different ways. So a medication like phentermine is a stimulant-type medication. It suppresses appetite. It works at the brain to tell you that you're not quite as hungry. A medication like Wegovy or Saxenda also suppresses appetite, but does it in a completely different way. There's a compound released in the intestines that tells your brain that you're full. It also tells your stomach to slow down its emptying. So not only do you feel full longer, but you also feel full earlier whenever you eat. So again, it gets back to this idea of trying to individualize the medication to the person to make sure that they're on the right treatment for them. So beyond medications, exercise is also a critically important part of any weight loss program. Again, this is getting behind that idea of treating obesity as a disease, trying to improve someone's health over their lifespan. So there's really three main rules when it comes to exercise, and this is well borne out in many studies where researchers have looked at this information. So this is what I try and tell my patients whenever I see them. Essentially, you want to work towards at least 2.5 hours of physical activity per week. This is above and beyond regular physical activity during the day. It's critically important to stay active during the day. Get up and walk whenever you have a chance. But there is no substitute for dedicated physical activity. It increases calorie burn. It'll generally cause about 25% more weight loss compared to just diet alone. And it helps with long-term weight maintenance. So for someone that's maybe been on a medication for several years and wants to get off of it, it's really important to have a healthy diet and a good exercise habit to improve their success at stopping a weight loss medication if that's the point that they come to. So not only is it getting that 150 minutes of exercise or more, it's also about doing it for at least 10 minutes when you do it. Now that's not to say if you have an opportunity to take a brisk 5-minute walk, don't skip that opportunity. It's still helpful. But those benefits really start to accumulate if you've done 10 minutes or more of physical activity. And then getting at this idea of the non-exercise thermogenesis. Stay active throughout the day. It increases calorie burn. It improves overall health. It's just good for you. So pairing all these things together, a healthy diet, regular physical activity with dedicated time for exercise and medications, we can improve someone's weight and their overall health. And that's ultimately what we're all here for as medical professionals, is to improve health. The last thing I wanted to mention about exercise, because this is a common question that I get asked, is how hard should you exercise whenever you exercise? Make sure you talk to your physician about that before you start an exercise program. There are certain medications that might affect that. There are certain certain medications you might be on that can affect that. So again, individualizing that decision is very important, but in general, you want someone to be at least moderate physical activity, which is the point where you start to break a sweat. You might be able to get out a full sentence, but then you have to take a breath. You can't speak in a paragraph like I'm doing up here without having to pause to really catch your breath. So you got to make sure it's intense enough to really get the benefits too. You combine, like I mentioned before, you combine all three of those, and they all improve overall health. So that's really what I wanted to say as far as medical management of weight loss. We talked about what obesity is. We talked about the fact that it is a complex disease. It is not just a question of willpower. Medications are very useful for treatment, and exercise is a very important part of any weight loss plan. So next, I'd like to introduce Dr. Greenwell. She's a bariatric surgeon that works with us. I've talked about medical options. She's going to spend some time talking to you about surgical options for obesity and how those contribute to weight reduction and improvements in overall health.
Hi, thank you all for having me. My name is Katharina Greenwell. I am a general and bariatric surgeon. The goal of my talk will be to talk about who qualifies for bariatric surgery, the weight management program as a whole at Mayo Clinic, bariatric surgery procedures that I perform, and what to anticipate before as well as after surgery. So Dr. Dilger already touched on this, but obesity is a very common and very serious disease. About 41% of the US population has obesity, and it's estimated by 2030 that about 50% of the population will have obesity or be overweight. So again, whenever we're talking about obesity, we look at where it says class 1, that third column over, that starts at a body mass index of at least 30. Again, you guys have already heard about some of the associated comorbidities that go with obesity, and this is one of the main reasons we really care about obesity and want to treat it. Those comorbidities include things such as high blood pressure or hypertension, high cholesterol, fatty liver, stress incontinence, urinary stress incontinence, gout, type 2 diabetes, as well as just quality of life. So a lot of patients that come see me, it's really because their obesity is starting to affect what they can and can't do. A lot of times patients tell me, I really want to be around for my children. I want to be able to play with my children in the yard, and I just can't do what I used to be able to do. Or even sometimes it's, more self-conscious sort of things, and it's very personal to them. So there's a lot of quality of life aspect that really goes into weight management. And then there's mortality. And I'll talk about that just a little bit later. There are at least 13 cancers that are associated with having obesity. Those are all listed there and you can read them, but some of the more common ones that we hear about are breast cancer and colon cancer. Again, as has been mentioned many times today, obesity is complex. There's a lot of things that go into obesity. It's not just about blaming a patient for how they ended up with obesity. There's their genes and the biology. There's their access to healthcare, access to education, access to healthy eating and the means to do it. What sort of life events have they experienced, and how are their coping mechanisms? How is a patient's mental health? Again, are they sleeping? The marketing that goes into what people buy, as well as just kind of the overall stigma about seeking help once you do have obesity or overweight, about actually seeking help from providers and getting some sort of weight management program. There are a lot of misconceptions, but these are ones that I personally hear from patients or colleagues very frequently. One is that bariatric surgery is the easy way out. If patients just worked harder, they'd be able to lose weight. Patients do not have enough willpower to control their own eating. You just need to eat less and work out more. Bariatric surgery is too dangerous. Or why undergo bariatric surgery? You're just going to regain all of your weight. This is another question I hear. I work out all of the time. Why can't I lose weight? Now, while I totally agree with Dr. Dilger, that working out and exercise is very important, and just overall being more physically active is very important. However, I also agree with the concept of that set point. And unfortunately, what we know is that when you do work out, while you will lose weight, your body, again, is still working against you. So once you have about a 10% weight loss, your metabolism will start to slow so that you will not lose the same amount of weight. Okay, so patients who are working out, while this is still important, they may find that they only lose a small amount of weight, and then they either regain it or can't lose any more, and they kind of plateau. The other thing that I'll say, and I'm sorry, this is just a little bit small, but surgery has been proven time and time again to be the most effective and durable treatment for weight loss. Now, I work very closely with Jamie as well as Dr. Dilger, and medical weight loss and nutrition is extremely important for many patients. However, when you look at the long-term outcomes, bariatric surgery is very beneficial. It's been shown to reduce the risk of premature death by anywhere from 30 to 50%, and that equates to 7 to 14 extra years of life. Patients will lose as much as 60% of their excess weight at 6 months, and up to close to about 80% of their excess weight at 12 months. One thing I do also want to emphasize is when we talk about weight loss, there's different ways to talk about it. There's total weight loss as well as excess weight loss, and those look at different things. So excess weight loss is the amount of weight that you're overweight, versus total is just like the total amount that you lose. So those percentages are different. So when you hear about that, or if you're talking to a provider, make sure you have them clarify a little bit, because that may be a little bit confusing, and I totally understand that. But to go on with this slide, at 5 years, you will find that the majority of patients have kept off at least 50% of the weight that they've lost. So that misconception about why undergo bariatric surgery, you're just going to regain the weight, it's not really true. And then the misconception that bariatric surgery isn't safe. It's actually quite safe. Nationally, the rates of any major complications less than 4%. The risk of death is well below 1%. And this is similar risk as some of the most common surgeries that general surgeons do, such as having a gallbladder removed or an appendix removed or a knee replacement. So who qualifies for bariatric surgery? These are updated guidelines just from this past year, and anyone who has a BMI of at least 35 should be considered for bariatric surgery, as well as anyone with a BMI of at least 30 and those associated comorbidities that we talked about. And then in the Asian population, it's accepted that their BMI should be, in general, their normal BMI is lower, so they should be considered for bariatric surgery with a BMI of 27.5. What are the operations that I do? I'm actually going to play a couple of videos from the Mayo Clinic website. They're just depictions, but this way, I think they explain them very nicely, and you guys can find them online as well.
In SWWI gastric bypass, the surgeon creates a small pouch at the top of the stomach. The pouch is the only part of the stomach that receives food. This greatly limits the amount that you can comfortably eat and drink at one time. The small intestine is then cut a short distance below the main stomach and connected to the new pouch. Food flows directly from the pouch into this part of the intestine. The main part of the stomach, however, continues to make digestive juices. The portion of the intestine still attached to the main stomach is reattached farther down. This allows the digestive juices to flow to the small intestine. Because food now bypasses a portion of the small intestine, fewer nutrients and calories are absorbed.
So that was the SWWI gastric bypass, and now I'm going to show a video of the sleeve gastrectomy.
In a sleeve gastrectomy, part of the stomach is separated and removed from the body. The remaining section of the stomach is formed into a tube-like structure. This smaller stomach cannot hold as much food. It also produces less of the appetite-regulating hormone ghrelin, which may lessen your desire to eat. However, sleeve gastrectomy does not affect the absorption of calories and nutrients in the intestines.
Okay, so in summary, how does bariatric surgery work? It ultimately restricts how much you can eat. Patients will feel full very fast. There's also a malabsorption component really to both of those surgeries, meaning malabsorption meaning you're not absorbing as many calories in the GI tract. There's hormone changes. Mainly those hormone changes are helping to control appetite or fullness. And then there are metabolic changes that happen as well. There are changes in your gut microbiome or the bacteria that live in your gut that help contribute to your metabolism. And all of these things in combination with diet and exercise help patients lose weight. So what can a patient expect from bariatric surgery? So as part of the weight management program, patients will meet with a dietitian like Jamie. We have another dietitian named Chrisanne as well. And they will see them at least 3 times for thorough education as well as education on a specific preoperative diet. Patients will also meet with exercise physiology. And the reason for this is because a lot of my patients have issues with mobility or issues with joint pain. And the exercise physiologists really help patients be creative and being a little bit more active in ways that work for them. Sometimes this is something just like using a TheraBand. Sometimes it's pool therapy. There's a whole lot of different things that they do. Patients meet with behavioral health. This is a very important component. It really helps patients adjust to their new lifestyle and develop new coping mechanisms and just really have extra support. I will not perform bariatric surgery on anybody who's currently smoking. It increases the risk of several things. So I do require patients to not use any nicotine for at least 3 months prior to surgery, and the expectation is that smoking cessation will be lifelong. Obesity is a disease, as we've all learned, that can affect really any organ in the body. And so depending on certain other factors, patients may have to see cardiologists or pulmonologists as well to evaluate the heart and the lungs. Patients will be on a low sugar, no carbonation diet. They will be expected to drink at least 40 ounces of fluid every day, as well as 60 grams of protein, and take vitamins lifelong. This may sound like no big deal, but it really is, and the reason why is because now their anatomy is different. Their stomach is very small. This can actually be quite a challenge for a lot of patients, and so they put in a lot of hard work to get to where they get to. After surgery, the patient will come in and stay overnight, usually 1 to 2 days. Patients will get up, move around the same day of surgery. They drink liquids the same day of surgery. And then when they leave the hospital, they have a lot of support and close follow-up. So they meet with me as well as a dietitian at 1 week after surgery, 3 weeks after surgery, 6 weeks after surgery, and it just keeps doubling out, really to make sure that patients are getting exactly what they need and that they know that they have a lot of support. They also will see their primary care doctor within the first couple weeks after surgery. And the reason for this is because we will find that patients will have a lot of medication changes in a good way. They will decrease their need for medications. The main thing being diabetes medications, as well as high blood pressure medications. A lot of my patients leave the hospital and do not need diabetes medications right after surgery. A lot of patients leave the hospital and do not need their blood pressure medications, or their dose has been lowered tremendously. I do tell my patients typically to take off about 3 to 6 weeks after work. And this really is because they just need time to adjust to the lifestyle. I really want them to focus on their healthy eating, staying hydrated, and that really can just take time. I find most patients want to go back to work between 3 and 4 weeks and are actually ready to. So what are common complaints that I get? Feeling full fast, or maybe some pain up here under, kind of like near the breastbone, and that's normal. It gets better. Patients learn to adjust to how they eat and separating solids from liquids and things like that. But that's totally normal. Common complaints of feeling bloated or constipated. Again, those tend to get better after the first 3 weeks or so. And then pain. Patients do really well from a pain control standpoint. Most patients do not even require narcotic pain medications, especially when they leave the hospital. And then nausea. Similarly, the first day, patients may feel a little bit nauseated. I work very closely with anesthesia to make sure that patients have good nausea control. And so far, patients have done really well. So to kind of summarize, what can a patient expect after bariatric surgery? With a gastric bypass, patients will lose between 60 and 80% of the excess weight, or the amount they are overweight. So if a patient is 100 pounds overweight, they will lose between 60 and 80 pounds. Granted, most of the patients seeing me are closer to 200 pounds overweight, so you can basically double that. With the sleeve, it's somewhere between 50 and 70% of excess weight. And this total weight loss that they experience happens over the course of a year to a year and a half, with the most dramatic weight loss in the first 6 months. And then very importantly is the resolution or improvement in many of their comorbidities. This includes diabetes, high blood pressure, high cholesterol, sleep apnea, as well as hirsutism, PCOS, or infertility. So that is all that I have. I'm going to turn the mic back over, and I believe we're going to start some Q&As.
We'll do that for the next couple of hours too, so. Yeah, no, for the next couple of hours, we'll take Q&A, so. Be okay with that? Just kidding. We'll be about 20, 30 minutes, or however long it takes, but I'll also state that our panelists will be here afterwards, so if you have specific questions, you wish to talk to them, they'll stick around, as many other Mayo staff will. So we do have a couple of mics that we'll be circulating around the room with, so please raise your hand, and we'll entertain those questions and turn them over to our panelists. So please, one in the back corner.
With obesity being a disease, if you will, do you see insurance companies paying more for the different drugs that are available now?
I'll turn that over to Dr. Dilger. He's the expert in that area.
I think there's greater acceptance of weight loss medications, so more insurance companies are covering them. It's unique to each situation, to each insurance provider. So that's one of the things that I frequently address with my patients whenever I'm seeing for a medical weight loss consultation, is if we don't know, it's important for that person to get in contact with their insurance insurance company and figure out which of those medications are covered, because the price can be shockingly high for some of the newer medications, and it's just not feasible to ask people to pay that. There are options outside of insurance coverage. Some of the medications like phentermine tend to be a little bit more cost effective, even if someone's just paying cash for them, not having them covered by insurance. So that is, I didn't mention it in my talk, but that is one of the things that influences medication selection for someone, is whether or not it's covered by insurance.
Maybe while we're on that same question, Dr. Mueller just stated this, how about coverage from the insurance companies for surgery?
So coverage for bariatric surgery also depends on the insurance that the patient has. I gave the updated guidelines for recommendations for who should be considered for bariatric surgery. This is also relatively new. So a lot of the insurance companies are using guidelines from 1999. And so that's also a challenge that we often face, where we have to discuss things, do a peer-to-peer and discuss things with insurance companies. With that being said, a lot of insurance companies do cover bariatric surgery.
Thank you. Next question. We got one in the front row here. We'll bring the mic up. Oh, we'll do you second. One right there. You got the mic there.
My
That's right.
question is similar, but it's more upstream maybe. What about coverage for a dietitian a little bit earlier on in the process related to insurance?
Yeah, that's similar to what the two previous providers said. Is insurance coverage really varies. So if you're interested in meeting with a dietitian, it'd be good to connect with your insurance company. But I feel like for a vast amount of patients, that's not a barrier.
If I might jump in, sometimes these conversations with insurance companies or coverage is easier if there are comorbidities like type 2 diabetes, high blood pressure, sleep apnea, osteoarthritis of the knees, the list goes on. So if you have overweight or obesity associated conditions, it's a different conversation.
I want to bring the mic right here in front. Thank you.
Thank you. So my question is, whoo, that is loud. My question is, the prescriptions that you showed up there, I'm assuming are all prescriptions that have to be prescribed by a doctor. Are there any over-the-counter type prescriptions that somebody like myself, I tend to run maybe 5-7 pounds overweight, spring hits, get a lot of exercise, manage my weight quite well. But I was always curious if there's any over-the-counter type prescription drug, not prescription, well, drugs that an individual could take that might be in my shoes. I work as an HR manager, and I have a lot of employees that are kind of in that same category, that maybe they don't need to go quite that far. You know, we can give them educational materials around nutrition and other topics that you've covered today. But I'm just thinking, is there any like type of program or advice that I can give my employees and maybe follow it myself? Thank you.
It's an excellent question. There is one that's FDA approved. That one's called Ally. So one of the names that I had up there was Xenical, and Xenical is basically just a stronger dose of Ally. Ally is the over-the-counter dose. It's a pill that's typically taken with meals. It helps block fat absorption, and as we already heard, fat is the most calorie dense of all of the nutrients that we get. So by blocking fat absorption, you absorb less calories, so it can help with weight loss. That's a medication that I just encourage a little bit of caution whenever people start it. If they have underlying kind of stomach or intestine issues, it can be a difficult medication for people to tolerate because it can cause a lot of bloating and some other symptoms. So if anyone wonders about that, talking to your physician about it is always a good idea. But it is available over the counter. It is a very safe medication, and it does help promote weight loss by blocking that fat absorption. But Ally, A-L-L-I, is how that one's spelled. That's really the one over-the-counter option. I don't encourage people to seek out weight loss supplements. There is no evidence that any of the weight loss supplements, vitamins, stuff like that actually promote weight loss. And a lot of times they have pretty significant adverse or negative effects for people. So avoiding supplements that are promoted for weight loss is a good idea. Ally is a safe medication that people can use over-the-counter to help with weight loss. It has been, yeah. It's been on the market for quite a few years now.
Thank you.
Thanks, Dr. Dilger. Next question.
That's a good segue into my question, which is about, there's a lot of information about trying to get people to eat healthier foods, and you hear food described as superfoods. You hear about micronutrients. You hear about anti-inflammatory properties and antioxidants and all of these things. But when you look into the research that's done to show that there are actual effects from these things, it's always inconclusive, or there's not enough research. And I'm wondering, why is that research not being done, or is there a good reason why it's not happening, and how do you avoid the misinformation that comes when there isn't hard evidence to back it up?
That's an awesome question. Nutrition is a science, and science is ever changing. So I don't think we ever have conclusive, data about anything, especially with nutrition, because we don't eat nutrients in individual, they're in combination with other nutrients, right? So oftentimes we see these foods have a synergistic impact. The nutrients interact together to have positive impacts. It's not that single individual nutrient. It's all of those nutrients interacting together. And I think our current dietary recommendations now focus on those overall patterns, not on individual foods or individual nutrients, because the benefits come as a whole. So I think, a lot of the information we have is about these overall diet patterns, and much of the data supports a plant-based diet because of those phytonutrients, antioxidants, all of those things that you kind of mentioned that we know can promote health when eaten in combination. So the fruits, the vegetables, the whole grains, the seeds, nuts, unanimously data supports that is a health-promoting diet. And it can help with weight loss too, as it's usually a lower calorie pattern of eating.
So I have a follow-up on that, on what we eat and what we consume. We're in La Crosse. So how much alcohol is unhealthy? Tell me about trans fats, and where are they? And I know we need to avoid them. And what are healthy carbs?
Yeah, alcohol is a challenging one, as what I've seen is kind of inconclusive. In that moderate amounts can be healthy. But again, is the alcohol what's health promoting, or is it behaviors of people who drink in moderation? Is it people who drink in moderation also have a better social life, also engage in more exercise? So it's hard to individualize that alcohol is the beneficial factor. But generally I say moderation is fine, which is no more than 1 drink a day for a woman or anyone over 65, or 2 drinks a day for a man under 65. But especially when we're watching our weight, as we're talking about weight here, alcohol has a lot of calories, so be mindful of that. What else did I want to say? Trans fats. So trans fats, we're kind of under that unhealthy fat. When I talked about, healthy versus unhealthy fats, unhealthy fats do include trans fats. Trans fats usually come from processed foods, although many food manufacturers have gone away with trans fats because we know how bad they are for our heart. Trans fats are also found in fried foods. And then saturated fats are usually the ones that are those solids at room temperature and come from animal sources, so bacon, butter, lard, that kind of stuff. And limiting your intakes of those and encouraging or eating more of those plant-based fats. Olive oil, canola oil, those fats are better for our heart. Oh, healthy carbs. Healthy, yeah. Yeah, healthy carbs, I think about our complex carbohydrates, or carbohydrates that have fiber and are minimally processed. So whole grains, brown rice, barley, and then fruits and vegetables contain complex carbohydrates. So whole fruits, whole vegetables, beans are also good sources of carbohydrates. That fiber allows them to be broken down more slowly, which helps promote satiety and fullness. Fiber can also help lower cholesterol, manage blood sugar, help with bowel regularity. So many benefits to fiber, and most of us don't get enough of them. So when we think about healthy carbs, look for carbohydrates with fiber.
I'll take on that. We're in Wisconsin. When you say a drink, is it a drink or a drink? You always have to be careful asking the question, how much do you drink? So anyway, next question.
Thank you. And I would have to say initially accolades, just outstanding. So thank you for what you're providing today. And Dr. Mueller, thank you for the overview of the medical center and everything that's happening there. Very exciting. My question goes back to comorbidity related to obesity. And way back when, there was a slide that showed mood disorders. And I would like to shift just a little bit the focus of the discussion on the psychosocial dimension and what anyone of the panel would recommend regarding the psychosocial influences, particularly social support.
I'll take this one, I suppose. So it's kind of like which one comes first, the chicken or the egg. And to be honest, it's really a vicious cycle. So a lot of times patients, part of the reason patients develop obesity, it may be because they already have some sort of mood disorder, whether it's anxiety or depression. There's a lot of things that go with it. And they may not have the best coping mechanisms. And that is one component. And then because of their obesity, this can exacerbate that. So then they may have anxiety about leaving the house and be able to do certain things. A simple example is, am I going to be able to walk the distance to get to where I need to get? Or am I going to be able to fit in the chair? And imagine living your life and having to think that way. And so these patients really deal with a lot of anxiety. And as you can imagine, that can really isolate a person. And I think that tends to be a real driving force as to why they end up coming to see one of us for changes. And then the other aspect is that's why we have such a strong behavioral health component as part of our weight management program, because we really want to make sure that before surgery, patients are really mentally making some changes, lifestyle changes, developing coping mechanisms to make sure that lifelong they can manage going forward. And then after surgery, they still have behavioral health support, and they meet with other patients that have gone through bariatric surgery, because what they go through may be different. Sometimes their self-image may be different, or even experience some guilt and things like that. There's a lot of things that patients go through, and so it's excellent for them to have other people to talk to and support groups, just to kind of share those stories and help each other out. I don't know if any of you want to add anything.
I would just emphasize, and you've heard this from our colleagues here, did you notice how we use the term people with overweight, people with obesity? We don't label them. We've gotten away from using terms like that's a diabetic or he's a we say person with diabetes. So it separates the problem from the human being. And that's a very effective way to communicate with patients that you have a condition, it has these health consequences and risks. It doesn't define you. You're a beautiful person, and we're going to take care of you and be with you each step of the way, whether it's through diet, exercise, medication, or ultimately surgery. We're doing this because it alters the course of your livelihood, and we can't underemphasize the data that Dr. Greenwell showed of how bariatric surgery in the right patient can save lives and lengthen lives in a tremendous way. That comes after the good work of my other colleagues first. You have to do that first, but I think separating the problem from the human being is critically important, and that nuance in the language is something to walk away with and remember. We don't want to label people. They have a condition we can treat.
If you don't mind, I'd like to add one more thing, because I spoke a lot about the negative aspect, about patients, dealing with a lot of negative things. But then they find afterwards that they experience a lot of positive things, and that they are able to do things for the first time in a long time, and that opens doors for them. That opens, it's kind of like how it's sunny outside, and all of a sudden everyone wants to be active again. And I think that losing weight certainly has that effect, and going through that whole program, whether it's even if it's not surgery involved, just experiencing that you're off certain medications and you can do things you couldn't do, really does help deal with some of that anxiety and depression.
I too would like to offer thanks and praise to Mayo for this wonderful learning experience. My question, I'm just not concerned, but I'm just curious to know, how many of these surgeries do you offer or have for this 1 year, let's say?
To clarify, the question is, how many do I offer in a year, or how many have I done in a year? How many have I done? So I'm a general surgeon, and then I did an extra year of training specifically to be a bariatric surgeon. In my career, I have performed over 400 bariatric surgeries, not including other laparoscopic stomach surgeries. Within the last year, I would say within fellowship alone, I did close to 300, so somewhere around there.
What else do you do with your time?
I run.
In between cases, that is. So
You can see we do our best to recruit the finest staff available, so she's been a great addition.
Since Dr. Mulling asked, a standard drink is
Yeah.
12 ounces of beer, that's 1 can, 5 ounces of wine, which is just over half a cup, and 1 shot of hard alcohol. So a Long Island iced tea is a binge in a glass,
yeah,
And
absolutely.
just so you know.
of course, everyone here wants to know about brandy.
Yeah. So, another question up front here.
I don't necessarily have a question.
Okay.
I would like
Yeah.
to say that the alcohol thing bothered me some years back. And I'm an old-fashioned girl, I am from Wisconsin.
Yeah.
Okay? But one of the things that I decided to do was look online for a non-alcoholic version of an
Yeah.
old-fashioned. There are so many recipes out there for different drinks that we drink every day. That are we drinking because of the flavor, or are we drinking because of the alcohol?
Yeah.
So like the old-fashioned, you take the brandy out, and you put in orange iced tea.
Yeah.
It's amazing. So just a thought, but I'd share that.
Oh, and I think that's a great tip. One of the interesting things that's kind of come about over the last 2 to 3 years is we've gotten more and more data on alcohol. Oops, I was talking a bit far away from it. So,
Yeah. Repeat the
yeah.
question.
Sure. So we were just talking about kind of non-alcoholic options, kind of just some tricks to mimic alcoholic beverages with the flavor in order to substitute that in place of alcohol. And one of the things I was just going to add on is that we've gotten more and more data over the last couple years that really shows minimizing your alcohol intake, even less than that 1 to 2 drinks a day if you're a woman or if you're a man, respectively, is actually beneficial for long-term health. The old data used to show, oh, you have a glass or 2 of wine a day. That's good. It mimics kind of what the French do, and they have low rates of heart disease. The Japanese drink alcohol, and they have low rates of heart disease. So it was primarily looking at it from a heart health perspective. And that data still holds true. But what we know now is that in terms of overall mortality, so overall risk of dying and other medical conditions beyond just heart health, less really is more when it comes to alcohol. And I know I'm in lacrosse, so I don't win a whole lot of fans amongst my patients whenever I tell them that. But honestly, that is what the data shows. So even in countries like Canada and the United Kingdom, where there's this really heavily ingrained drinking culture, they're emphasizing less and less alcohol. And eventually that's what our kind of national groups will recommend. It just hasn't gotten there yet because there's a lot of resistance to that idea. But it's what I tell my patients. Less really is more when it comes to alcohol.
And really what you've done is provided an excellent behavioral tip. And you see this in the literature a lot. I'm sure our colleagues here recommend this as well. But if you're somebody who's a snacker, you've got those cravings, get them out of the house. Because I tell my own wife, if you put those orders, I'm going to find them.
Yeah.
I will find them.
Sniff them out.
So you want to get them out of the house, and you want to have an alternative. So maybe it's celery sticks or an apple or something, go for a walk. But we will have patients look at those behaviors and I'll ask them, what's your vulnerable point? Is it pastries from Blado's in Winona? Don't go there.
Yeah.
Is it Oreo those are the kinds of things that you can actually do and work with your family and whomever you live with to take that out and find a substitute activity, and that's pretty effective. For some, it's chewing gum, some it's drinking
Yeah.
a big glass of water, others tips like that.
Behavioral modification of your habit. So, question in the back?
Thanks. What can you tell us about fasting and maybe the benefits
Yeah.
or pros and cons, and then what a good schedule is for that? And then I had another question about the set points. You talked about what makes those go up. Is there any good ways to lower the set point? Thank you.
I'll maybe take the fasting question first. The research I've seen on fasting is it can improve metabolic markers like fasting blood sugar and cholesterol levels. In terms of weight loss, I've seen the data really isn't showing that fasting's any more effective at weight loss in that like 1 year mark. And most of the research on like diets for weight loss look at things through a year. So I think if fasting is something you feel is achievable and maintainable, it certainly can help with weight loss. I always encourage patients to select a diet approach that they feel is maintainable. Because as soon as we stop the fasting, we typically, or stop whatever diet you're on, we typically see that the weight comes back. So choosing something that feels maintainable for you is really important when we're looking at long-term success in terms of weight. As far as like what type of fasting is best, I don't think we have research to say that one type of fasting is more effective than others. There's, like the time restricted eating or alternate day fasting, and I don't know if I have seen research, and other people can speak up if they have, that one is more effective than the other.
I'll just address, I know Dr. Greenwell's excited to address part of the set point question, but that's one of the things that we specifically address with medications, and whenever I see patients for weight loss consultations as well. It's about identifying some of those behaviors that we might be able to affect some kind of change, because if someone's not getting enough sleep, sometimes it really can help to actually get the right amount of sleep. I've also seen it where patients, if they have it's stress management is it's a very critical thing in overall health. It is not just obesity. It plays a role in heart health, mental health, all those different facets of life. But it can be really difficult to control that when the stress comes from outside places like a job. But I have seen it where some of my patients retire and they're healthier after they retire because they don't have that outside stress on them. So I try and identify some of those specific factors that play a role and work with my patients to come up with a plan to address them. And then medications also help in that regard well. They actually help that set point to be lowered so that while you're taking the medications, it helps maintain that lower body weight. That's why we tend to see weight regain whenever people stop them, is because that set point is allowed then to go back up to where it was originally. It's why obesity is a long-term chronic illness, is because we constantly have to work against our body's natural tendency to gain weight once that trend has been established.
I was going to say something very similarly, except for bariatric surgery is a bit more permanent in that you have certain hormone changes that happen, especially in the early post-op period. So, whenever you work out and you increase your metabolism and you're burning more calories, that set point kicks in to try to make you eat, and you get the sensation that you're hungry. But with bariatric surgery, you get changes in hormones so that you don't necessarily feel hunger the same way. You have hormones that are communicating in a different way so that your metabolism is actually changed. So it's like the thermostat's broken and it can be 90 degrees all day. So that's why patients lose weight and keep it off long term after 5 years.
I have a question. Some of this information is really very positive and something to look forward to as far as the medications that are available, which would become probably more and more used by a lot more people, especially when insurance starts to cover them. But my question is really more around obesity in children. As we know that's become another almost epidemic. And I guess my question is, are we using these medications and or surgeries to curtail obesity in our young people, or is that not an option at this time?
No, it's certainly an option. And as for myself, I treat adults. I don't treat pediatric obesity per se, besides kind of diet, lifestyle, the behavioral interventions that I offer whenever I see children with obesity. We have colleagues in pediatric endocrinology where that is what they do. There are medications that are FDA approved to help treat obesity in children because we recognize that as an increasingly common problem. I focused on it in adults because that's who I treat, but we see it pretty frequently in kids that just come in for their routine well-child visits. So addressing it at an early age, we hope to kind of reset their trajectory in terms of weight gain so that they don't end up with weight-related issues at a much earlier age than they would otherwise.
Yeah, we bring in a host of pediatric endocrinologists that do come here to La Crosse, and oftentimes I refer directly to them for those. Kathy, you are correct. It is becoming a major epidemic in this country. and hopefully intervene early before the comorbid conditions kick in.
Bariatric surgery is technically an option for children with obesity. I do not perform it in children as of yet, but there's not a limit on either extreme of age. As far as we can tell, it's been proven to be safe in both children as well as older patients. Patients that are in the pediatric population tend to get sleeves more than bypasses at very specific centers, just because children also have a lot of other issues and things that should be considered as well that aren't necessarily in the adult population.
Question in the back.
I'm more a proactive person, so I'd like to know, what do you recommend for like somebody who maybe is a 68-year-old woman who's in a normal weight category, like how much fiber, how much protein, how much healthy fat do you want us to get per day?
That's a loaded question that has a lot of nuance. So if you're looking for individual recommendations for yourself, I would suggest working with a dietitian. As you know, medical conditions, activity, age, gender, those things all influence how much of those things we need. If you're looking at counting those specific things and want those specific numbers, working with a dietitian would be important. Otherwise, we don't eat nutrients, we eat foods that have nutrients. So I think focusing on that, reading labels, yeah. If you're looking at certain amount of fat or sodium, that's going to have nuance that I couldn't answer right now. So meeting with the dietitian can be helpful if you want that level of detail.
So thanks, Sue. In follow-up of that, I'm an internist, so I see a lot of patients who have obesity or overweight, and this question comes up. One of the things out of the chute, and I'd like to ask my colleagues on this, is how do you evaluate the patient who has overweight or obesity? What kind of medical workup do you do? What should you look at thyroid disease? Should you look at what medications they're taking, which plenty will enhance, they'll cause you to retain weight or gain weight. But one thing that I find fairly common is the inadequacy of physical activity. So most of you, or many of you, have smartphones with you. You can probably look on it right now and see what your step count is for today. And it's right there, we can show you. Secondly is really not really having a good handle, not just on what calories are intake, because you want a calorie deficit, as was pointed out, if you have overweight or obesity, but how many do you need in a day? And there are calculators available online to actually estimate pretty accurately what your caloric need is for a given day if you did nothing. And I always encourage my patients, keep your calorie intake below that number, because if you couple it with exercise, you will lose some weight. And we'll look at your medicines, we'll do a medical workup as well. The reason I say that, because you see those TV ads, this is for a 2,000 calorie per day diet in a US adult. That's probably too much for a lot of people, right? Most of us are pretty energy efficient, turns out, and we don't need that many calories in a given day, even if we are pretty active. For a smaller woman, it might be only 1,400 calories a day, and that isn't all that much. You can do that in one sitting at whatever restaurant you like.
So, Paul, what I'm wondering about that is, like, how many grams of protein
Yeah.
should a person look for? Is that different with everybody? Or
It does differ.
It's different between a 40-year-old and a 68-year-old?
Mhm.
Oh.
Yeah, and
Are there charts for that online?
yes,
Okay.
yeah, we can. You want to comment on kind of general approaches at first, Dr. Dilger or Jamie or?
Yeah, I'm happy to talk about just kind of general approaches to overall health, weight maintenance in my patients that are maybe they do have obesity, but they're not looking to lose a lot of weight. They just want to maintain their health. When I see patients, and that's the discussion, I tend to focus in a lot on physical activity. And my diet recommendations, I always offer a visit with a dietitian, but my main thing is to emphasize the importance of that physical activity, getting that 2.5 hours of dedicated exercise time a week or more, less if you really can't allocate the time for it. But on top of that, the regular physical activity. Studies have consistently shown that kind of 9,800 steps per day, so 10,000 if you're rounding, is really where people seem to benefit when we're just tracking physical activity to improve overall health in a number of different areas. So I really heavily emphasize physical activity. I think it's probably the most important thing we can actually talk with patients about is their physical activity in terms of preventative health. In terms of diet, I usually emphasize a diet that's low in processed foods just in general. Processed foods have nutrients stripped out of them. They're nutritionally devoid. They add in a few vitamins and minerals to essentially make it look good on the label. But any of those good micronutrients that we might not measure but interact in those synergistic ways that Jamie previously mentioned, all those get stripped out. So it's a lot of calories with not a lot of nutrition. So I place a lot of emphasis on exercise and physical activity throughout the day. I place a lot of emphasis on avoiding those processed foods and really focusing on a diet that's low in those, richer in a lot of whole foods, plant-based foods, things along those lines.
And limit the calories to what you need. The other thing about physical activity that can't be overemphasized, it isn't just about burning calories. All of those things on that list of diseases associated with obesity can be mitigated by regular physical activity through other mechanisms, not just calorie restriction. So prevents falls, better mood, lower blood pressure, better heart. The list just goes on and on, so it's quite remarkable.
You have a comment?
I think my approach may be quite a bit different than both of theirs, because by the time they've gotten to me, I really rely on my other providers to go through a patient's diet and their physical activity levels, and that's why I have a whole team. So my approach really focuses more on what is the goal, why did you come see me, and then what are we trying to improve by having bariatric surgery. From there, I focus on the medical comorbidities that a patient has. Oftentimes patients will end up having other workup by a cardiologist or a pulmonologist because obesity does affect your breathing and affects your heart chronically. And then I also focus on, do they have diabetes as well as reflux, because the surgery that they get will depend on the comorbidities that they have. So for example, there is a calculator that I use that has been validated multiple times to show the chance of diabetes remission in patients who undergo a certain surgery. Remission meaning being totally off any diabetic medication long term. And we tend to see that as much higher in a gastric bypass. And oftentimes, if you've had diabetes for a shorter period of time, even if you're on insulin, if you have good diabetes control, it's over 90%. And so that patient, to me, gets a certain surgery. The same with reflux. It tends to be a little bit better in a bypass, but ultimately, a lot of times patients come to me and they have a concept of what they want. They've either watched videos or they know somebody who's had something. And so I really try to make the decision with the patient after explaining the pros and cons of either one of them.
I always state to my patients that I can treat that with a pill that takes care of one thing, or we can talk about diet and exercise, which, as many of the what is stated here, it treats the whole person, and much more emphasis needs to be applied on that versus just taking the pill. So, another question?
Is there any truth behind eating smaller portions more often during the day that genuinely actually helps increase metabolism, or is it just that you look at calorie count for the entire day?
Yeah, I think I talk about our metabolism as being kind of like a little fire, and our fire tends to burn better when we throw like kindling on it throughout the day versus, prolonged fasting or extreme calorie restriction can result in our metabolic rate decreasing. So I think, every person does better with a different diet approach. Some people do best with 3 square meals. Some people do best with small, frequent meals. So I don't think there's a one-size-fits-all diet approach. But generally, I encourage people to eat regularly throughout the day. And if that's 5 or 6 small meals, then that's what works for you. But I do tend to believe that eating throughout the day is what's best for our metabolism. And Dr. Mueller wanted me to address, is there a best diet, one best diet? No, I don't think there is a one best diet. I think the best diet is the one that you can stick with. So choosing a eating approach that feels sustainable to you, because we only get the benefits for as long as we can sustain that diet approach. So choosing a diet that feels like something you can stick with for the long haul, that's what's important. too. I eat lots of snacks, and my dentist tells me not to do that. But that's what works best for my body. So,
Do we have any other questions? All right, our panelists will be here afterwards, so if you do have individual questions or wish to meet our panelists or any of our staff, please let us know. I also want to thank our panelists. This is hopefully informational, transformational to our attendees. We want to be community partners. We want to be here, get the real truth out there, what we need to be doing. So with that, on your tables, there's information that you can review. It has the panelists on there. It has a bunch of other recipes. It also has a QR code in there. So please let us know how we're doing. I also want to point out, Kim's right here, Kim Noth. Kim Noth's been with our system how long? 33 years. So thanks, Kim. She has taken this project on with our weight team management. So thank you, Kim, for doing that. But if you have questions for her about the program in itself, too, please reach out to Kim. Also, kind of gratitude and thanks to all of us, those that helped us put this on. To do this takes quite a bit of effort and work. Peter's back there, Lynn, Tara, everybody who helped put this together, so thank you. The other thing I want to point out, and lastly, I cannot say enough, much for our auxiliaries. They are fantastic, wonderful people who made Mayo Clinic, St. Francis, Skimp, whatever you want to identify as today, who they are today, and still are true to the cause. They have the geranium sale. I'm going to put a plug in, so please purchase some geraniums from them, because all that money goes right back into our community, education of our nursing students currently. So with that, we'll conclude our program. Please feel to come up and ask questions you want. Otherwise, please mingle. Whoop. Comment.
Sorry, I should have pointed you out, Kim, but I just wanted to say that she's the bariatric surgery coordinator, so if there are ever any questions about insurance or who qualifies, she really helps patients navigate that and make sure that they get what they need from the program. So she's really my right-hand woman and does a great job at that. So thank you, but also she's very helpful if you have any questions.
Yeah. All right, with that, the program's concluding, so thank you.
Falciform ligament coming in and the umbilical fissure, dividing the liver into dividing the left lobe into medial and lateral segments. So superior, mid, and inferior parts. Another point that I'd like to bring up here is about the